So we'll continue the medically compromised chapter from therapeutic guidelines, and we are at page number 174, which is cancer. Dentists have an important role in initial recognition and diagnosis of oral cancer. If a patient who has had head and neck treatment has a suspicious oral lesion, who has had a cancer treatment actually, refer for investigation to exclude cancer recurrence or a new primary cancer. So we have read about the red flag lesions in the beginning chapter. It is on page 93. So there we are to reassess ulcer more than 3 weeks of duration. That way we have to take into consideration and send these patients for biopsy. Metastatic cancers to the oral soft tissues and jawbones commonly originate from primary malignancies in the breast, prostate, kidneys, and lungs. Leukemias and lymphomas may also present in the oral cavity, and we have read about red flag lesions before. Then chemotherapy. Ideally, patients should be dentally fit before starting chemotherapy, like it was for MRONJ. The similar osteoradionecrosis is the same disease or occurrence. One happens with the medicines, other happens with chemotherapy. Particularly if chemotherapy used can cause severe mucositis and reduce salivary flow. For the management of these complications, we have previously done regarding dry mouth and oral mucositis. Some types of chemotherapy cause immune suppression and increase the risk of oral infections such as oral candidiasis, herpes simplex virus infection, and post-operative infection. So develop dental treatment plans in consultation with patients treating specialist or multidisciplinary team. That's how we go about multidisciplinary team referrals. They love these things because they are testing professionalism of a dentist. So all this would go in there. Some types of chemotherapy cause significant neutropenia and thrombocytopenia, particularly with treatments for leukemia and lymphoma. Patients with neutropenia or thrombocytopenia require specialist management for dental treatment. Perform dental procedures when the neutrophil and platelet counts are adequate. So that's why specialist management, but when still the levels are somewhere adequate to work on. Seek expert advice for emergency dental procedures. Otherwise, schedule it after they have met the adequate numbers. Then tooth extraction socket heals well in most patients undergoing chemotherapy. However, those taking anti-resorptive or anti-angiogenic drugs, the same thing which was covered in medication-related osteonecrosis of jaws, are at risk of MRONJ, and for them, we need to send them to specialist advice. Especially they have a comorbidity here that they are under, radiotherapy. Then we have, this is chemotherapy. Next is radiotherapy. So patients who require head and neck radiotherapy should be reviewed by a dentist experienced in cancer management as a part of multidisciplinary team. So radiotherapy can cause oral pain, mucositis, reduced salivary flow, oral infection, trismus, and altered taste. Reduced salivary flow can increase the risk of periodontal disease and dental caries. And good oral hygiene can reduce the incidence, severity, and duration of adverse effects associated with radiotherapy. Ensure optimal oral health. If possible, any necessary dental treatment should be completed before starting radiotherapy. So again, the same thing. With chemotherapy, radiotherapy, and medication-related osteonecrosis, all dental treatments before starting them. If extractions are performed, allow adequate time for wound healing, usually 10 days to 3 weeks before starting radiotherapy. So it is these things are important. When Ronj we read, before the next medicine, just schedule the procedure as close to as late as possible and just before the next medication dose. In head and neck radiotherapy, again, before starting the procedures, and if extractions, 10 days to 3 weeks in advance of starting radiotherapy, so that the sockets would have healed properly. 21 days is actually the time when the wound healing by secondary intention gets completed. So that's why 3 weeks. Patients who have had head and neck radiotherapy are at increased risk of osteoradionecrosis. Encourage regular dental review and seek advice from the patient's multidisciplinary team before performing tooth extractions that are within the field of radiotherapy. If possible, choose conservative dental treatment options like periodontal treatment, restorations, endodontic treatment, root canal, and fluoride application. Neutral fluoride products are better tolerated than the acidulated products. Management of osteoradionecrosis is difficult and requires specialist management. So use neutral fluoride. APF is not advisable, and all the patients who are even at risk of osteoradionecrosis, you have to refer them to the consultant specialist for their dental work. Do not extract teeth from a patient who has had head and neck radiotherapy without consulting the patient's multidisciplinary team. So you have to refer them to multidisciplinary team, to their specialist. Then next disease which is starting is cardiovascular conditions. In cardiovascular conditions, the first is which is a normalcy, a normal finding in most of the population in present epidemiologic of the disease. It's elevated blood pressure. Patients treated for elevated blood pressure can undergo general dental treatment if their blood pressure is controlled and stable. So patients should have had their medicines and should have been on continuous regimen of lifestyle maintenance or of blood pressure management. And then no problem, we can do their general dental treatment in the outpatient clinics. Although LA containing adrenaline theoretically elevate blood pressure, they do not have clinically significant effect. So we should use proper adrenaline containing LA. Then avoid NSAIDs in patient taking diuretic plus angiotensin converting enzyme inhibitor, which is perindopril, or angiotensin 2 receptor blocker candesartan. So in this, you are not prescribing ibuprofen because combining these 3 drug classes can cause kidney failure. So which 3 drug classes? NSAIDs, angiotensin converting enzyme inhibitor, and diuretic, or NSAID, diuretic, and angiotensin 2 receptor blocker. Alternating analgesics, paracetamol can be recommended to select appropriate. Okay, we have done with whatever is a contraindication for giving ibuprofen or NSAID, their paracetamol takes the center stage. Then we have calcium channel blockers. Example, amlodipine can cause gingival enlargement, gingival hyperplasia. Gingival enlargement can be minimized with good oral hygiene. However, extensive gingival hyperplasia requires specialist management. Okay. Then we have coronary ischemic syndromes. This is, what is ischemia? Thinning or the thickening of the blood vessels, which shortens the lumen of the arteries. Okay, and there is a lack of oxygen carrying capacity because of this process. So in dental practice, first aid management of angina or an acute coronary syndrome is outlined, that we would deal with the medical emergencies in dental practice. If it happens so that lumen is completely closed. Okay, that is a block temporarily. That is goes like a pain in the retrosternal area, which we refer as angina pain. And ischemia is progressive narrowing of the arterioles. So check if the patient is taking antithrombotic drugs, because this was antithrombotic drugs will have bleeding tendencies. So we would go back to our regimen of antithrombotic drugs, how to take care of those patients. In the 12 months after myocardial infarction, stent placement or coronary artery bypass surgery. So you have to have an history of taken from these patients in the last 12 months. If they have had MI, stent placement, or coronary artery bypass surgery, patients are at increased risk of major adverse cardiac event, which is sudden death. Defer elective dental treatment for 6 months after myocardial infarction, stent placement, or coronary artery bypass surgery. So this is deferring the elective dental treatment. But if dental pain or infection occurs within the 6-month period following the event, provide adequate emergency treatment in order to defer definitive treatment and consider seeking specialist advice. So very important highlighting point, no elective dental treatment for 6 months after these procedures. And patients with a history of coronary ischemic syndrome can undergo dental treatment as long as their condition is stable and they are following their preventive or rehabilitation program. The presence of pre-existing coronary stent is not an indication for surgical antibiotic prophylaxis for dental procedures. So a stent being there in the artery system is not an indication to give antibiotic prophylaxis. Indications for surgical antibiotic prophylaxis we will read next after a while. And then we have instruct patients with angina to bring their medication, which is the GTN spray or tablets, when attending their dental treatment, and have it in a readily accessible place. Limit the duration of dental procedures, use relaxation techniques, and consider anxiolysis. For advice on anxiolysis, minimal sedation or dental procedures, we would go to the relaxation part of the dentistry, the drugs, the diazepam and stuff later. Ensure effective analgesia during dental procedures using LA is effective, and pain control is well established, because dental pain exacerbates the stress, and that can be, any kind of a major stress can be dangerous. So ensure that LA is working before you start, say, doing extraction or anything. Use of vasoconstrictor in LA is not contraindicated, so you must use LA with vasoconstrictor. Then we have heart failure. Do not undertake dental treatment unless patient's heart failure is stable. Again, defer the elective dental treatment. That means limit the duration of dental procedures in them. Patient with heart failure may not tolerate being placed in a horizontal position. So position the dental chair so head is higher than the heart at a similar angle to how the patient can comfortably sleep. Patients with severe heart failure are at increased risk of adverse outcomes from sedation and GA. Dental procedures requiring sedation or GA should be undertaken in a hospital with an anesthetist present. So in these patients, to all these procedures, even in sedation and GA can be a risk, and dental procedures would need to be taken in a hospital, not in the outpatient setting for patients with heart failure. Avoid NSAIDs in patients with heart failure. So you would go ahead with paracetamol for pain relief prescriptions. Then we have cardiac implanted electronic devices, which is pacemakers they are referring to. So these are cardiac implanted electronic devices, include implantable cardioverter defibrillators and permanent pacemakers. Patients with cardiac implanted electronic devices can undergo most general dental treatment. Surgical diathermy can interfere with some cardiac implanted electronic devices. So that surgical, when we use that electrode-like thing for surgeries, so that can interfere with some cardiac implanted devices. With modern cardiac implanted electronic devices, interference from most other dental electronic and ultrasonic devices is usually not clinically significant. However, if in doubt, consult cardiologists responsible for management of these pacemakers or seek expert advice before a dental procedure. So if in confusion about ultrasonics or anything, we can consult and ask advice. Presence of cardiac implanted electronic device is not a specific indication for surgical antibiotic prophylaxis. So having a pacemaker is not surgical antibiotic prophylaxis advice, not an indication per se. Cardiac implanted electronic devices should not be confused with prosthetic cardiac valves. Presence of cardiac implanted electronic device is not a specific indication for infective endocarditis. So separate it out in mind. What is a implanted device, which is a pacemaker? What is a valve? Valve is plastic or artificial material to increase the patency of the vessel, whereas this is just to this implanted devices for electronic are to give regular rhythm to the heart. That lubbed up exact rhythm is what is their meaning for electronic devices. So this completes the heart conditions. We would deal with the infective antibiotic prophylaxis in the later part of the chapter. And next session, we will start with diabetes. Okay. You have any doubts?
No, ma'am.